So we're going to talk about blood transfusion therapy. So this here is whole blood, right? So when we get when people donate blood, they're going to donate their whole blood, and then that blood is spun, and they can get different components of the blood and separate them out. So whole blood is 55% plasma. So the plasma proteins are in there. Some of the clotting factors are in there. There's less than 1% that's white blood cells and platelets. So they can separate out the platelets, and sometimes they separate out the white blood cells as well. And then 45% of the whole blood is packed cells. So the red blood cells is 45% of the whole blood. So the different blood components that can be separated out of whole blood include packed red blood cells. They can freeze those red blood cells, so they can have frozen red blood cells, platelets, fresh frozen plasma, albumin, cryoprecipitates. There's also some commercial concentrates of those cryoprecipitates. And whole blood is rarely used. It's used during hemorrhage or shock, hemorrhagic shock, where you're losing a lot of blood. If you give somebody whole blood, high risk for developing fluid overload, unless they have lost a whole lot of blood. So generally, a unit of whole blood is about 500 milliliters per unit. So again, here's the composition of blood. Plasma, we said that 55% of whole blood is plasma. Within the plasma, we have the plasma proteins, we have some nutrients and some hormones. This less than 1%, that's white blood cells and platelets, contains the white blood cells and platelets. That's also known as the Buffy coat. And then the red blood cells, right? So the packed cells, we said, is 45% of the whole blood, and that's this component here. So here's a normal hematocrit level for males and females. Okay, so the packed red blood cells, usually they come in a volume between 3 and 350 milliliters per unit. So something that you need to be aware of when you hang a unit of blood is that not all units have the same amount of volume in the unit. So you need to document how many milliliters are in that unit that you're hanging. So the packed red blood cells is removed from the plasma. From whole blood, about 2/3 of the plasma is removed. They also remove most of the white blood cells. And if you remove the white blood cells and the plasma from the whole blood, that reduces the risk of a reaction. So a lot of people that have reactions actually have reactions to the white blood cells of the donor. So if you can take those out, if you can remove those, that decreases the risk of a transfusion reaction. And we're going to talk about different types of transfusion reactions. The drawback is that when you donate blood is that you could have some contamination of the blood during the collection or during the processing of the blood. So oftentimes, like I said, when people have a transfusion reaction, they have a reaction to the white blood cells of the donor blood. So sometimes the doctor might order a leukocyte filter. This is a picture of a leukocyte filter. So this filters out the white blood cells. So generally, if you have a patient that has had a reaction in the past, the doctor might order leukocyte poor red cells, or they might order a leukocyte filter if they've had a history of a febrile reaction. So we're going to talk about different types of reaction. Febrile reactions are usually due to the white blood cells. So the packed red blood cells is the most commonly used blood component. Um, the shelf life of a donated unit of blood is about 42 days. So once somebody donates blood, we have about 42 days to use it. It takes about a day to process. If you give a unit of packed cells, you're going to have less chance of fluid overload than if you administer whole blood. There are no viable platelets or granulocytes in a unit of packed cells. If you give somebody incompatible blood, then you're going to have what's called a hemolytic reaction. And like I said, we're going to go over the different types of reactions. And so you need to be familiar with the signs and symptoms of the different types of reactions and the different treatments for the different types of reactions, because you're going to treat each reaction differently. So if you give somebody incompatible blood, and we're going to talk about compatibility, then they're going to have a hemolytic reaction, which is the most serious type of blood transfusion reaction. So the purpose of giving blood is to increase the oxygen carrying capacity in patients who either have a slow bleed or have anemia or require surgery or they've lost blood for whatever reason. It's usually indicated when the hemoglobin is between 8 and 9 and the hematocrit's between 24 and 27. For each unit of packed cells that you administer, the hemoglobin should go up by 1 and the hematocrit should go up by 3. It takes about 4 to 6 hours post-transfusion for that H&H to change. So if you have a low H&H, you're going to monitor that, and you can expect that H&H to go up about 4 to 6 hours after you give the blood transfusion. So in order to prevent blood transfusion reactions, we have to type and cross the blood in the donor. Now there's different types of blood, and the most common type is O positive. 39% of all the people have O positive blood. The next most common type is A positive. 34% of the population has A positive blood. Then the next one is B positive, 9% of the population. And then the next is A negative, 6% of the population. Actually, O negative is 7%. So O negative is next, and then A negative. And then AB positive is 4% of the population. B negative is 2% of the population. And AB negative is only 1% of the population. So who knows who the universal donor is? The universal donor is O negative. So O negative is is blood that is very sought out. They seek that blood because you can give O negative blood to anybody. But only 7% of the population has O negative blood. AB positive blood is the universal recipient. They can receive blood from anybody, but they can only give blood to O negative. They can only give blood to AB positive people. So they can receive blood from anybody, but they can only give to AB positive people. That's 4% of the population. 7% of the population can give blood to anybody, but they can only receive O negative blood. So most people have two related inherited antigens. So you either have antigens for A or antigens for B. And that forms the basis for the ABO blood typing. So people that have the antigen for A have type A blood. So you can give them A blood. If you give them B blood, they're going to have a reaction. Individuals that have type B antigen, you can give them type B blood. If you give them A blood, they're going to have a reaction. Individuals that have both A and B have antigens to both of them, so therefore you can give them either A or B. And people that have neither antigen, Those are type O blood. So you cannot give type O blood, you cannot give them A or B. They can only receive O. So antibodies with each blood type. So if you have type A blood, you have antibodies against B. So you cannot give B blood to a type A person. Type B blood has antibodies against A. So you can't give A blood to a type B person. People that have blood type AB, they have no antibodies. So you can give them A or B. And blood type O has both antibodies, so you cannot give them either A or B because they'll have a transfusion reaction. Another thing that you look at when you're typing the person is whether or not they have an RH present. If they have RH positive, then that means that they have that RH. If they're RH negative, they don't. If an RH negative person receives RH positive blood, they're going to develop antibodies. So if you can give an RH positive person RH negative blood, but you cannot give an RH negative person RH positive blood. So this table here will help you determine who you can give blood to. So if you have type A positive, you can give blood to an A positive person or an AB positive person. You can receive blood from an A positive person, an A negative person, an O positive person, or an O negative person. So here is this table. So an O negative person is the universal donor, right? They can give blood to anybody, but they can only receive O negative blood. Yes? So these people are very generous. They can give to anybody, but they can only receive O negative. The AB positive people, they're the greedy ones, right? So they can receive blood from everyone, but they can only give blood to AB positive people. So just figure it out. I think it's easy to understand. If you have a positive blood, you can receive a positive or a negative. If you have A blood, you can only receive A blood or O blood. If you have AB blood, you can receive anybody. If it's AB positive, you can receive anybody. If you have AB negative, you can receive A negative or B negative or O negative. Okay, so just go through this and remember what the blood types are and who can they give to and who can they receive from. So remember, the universal recipient is the A positive people, right? They can get from anybody. They can get O, they can get B, they can get A, they can get AB, right? Only 4% of the population is a universal recipient. And then the O negative people, they can give to anybody, right? They can give to AB positive people, they can give to A positive people, they can give to O positive people, they can give to B negative people, B positive people, A negative people, AB negative people, right? They can give to anybody. They're the universal donor, but they can only receive O negative blood. So when somebody donates blood, they're going to be typed to determine what type of blood it is. And once you have a recipient, they're going to cross match that blood to make sure that those are compatible. So when you type the blood, all it determines is what type of blood is it? Is it AB negative? Is it O negative? So they're going to determine the ABO group and the RH factor. That's what typing is. They're just figuring out what the blood classification is. When you have an actual recipient that needs to receive blood, they're going to now cross match it to determine compatibility between the donor and the recipient blood. So if you have a unit of blood that's typed in the blood bank, all that's been done is that they determined the ABO group and the RH factor. That's all that's been done. If you have a type in cross, That means that there's a unit of blood waiting for a specific recipient. They've cross-matched it between the donor and the recipient, and they've determined that that is a compatible donation. So there's a, if they say that that patient's been typed and crossed, that means that that patient has a unit of blood waiting for them in the blood bank that has already been determined that's compatible for that patient. It's been labeled with that patient's ID. So if it's typed and crossed, that patient's going to have a label on their wrist that looks like this. If they have a label on their wrist that looks like this, that means that there's a unit of blood waiting for them in the blood bank. They've been typed and crossed. There's a number on that wristband that matches up with the number on a unit of blood in the blood bank that's waiting for them. So when you test somebody for compatibility, it takes about an hour to identify the recipient ABO and RH type. So if you are having an emergency where the person is exsanguinating and you don't have an hour to wait to identify the ABO group and RH type, what blood would you give that patient? You would give them O negative, right? The universal donor. So in an emergency situation, you're going to give O negative. It can be given safely to most people without any serologic testing. Whenever you are getting blood from the blood bank, you need to sign it out. If your patient is getting multiple units of blood, you cannot sign all the units out at the same time. Only one patient at a time and only one unit at a time can be signed out from the blood bank. So you're going to go to the blood bank, get the blood, hang it, and when you're ready to hang the next unit, you go back down to the blood bank and get the other unit. Okay, now we're going to talk about platelets. Platelets usually come in units that have between 30 and 60 milliliters. So again, the volume is going to vary, and so you need to document the volume of the unit of platelets that you're hanging. Who would get platelets? Anybody that has thrombocytopenia. If you have a platelet count usually less than 10 to 20,000, then you're going to get a platelet transfusion. What's a normal platelet count? 150,000, right? So 10,000 is really low. You're at risk for spontaneous bleeding. So if you have a thrombocytopenia where your platelet count is less than 10 to 20,000, the doctor's going to order a unit of platelets. Each unit of platelets will increase your platelet count by about 10,000 per unit. And you want to measure the platelet count about an hour. And again, 24 hours, 18 to 24 hours after you administer the platelets. So you can expect the platelet count to go up by about 10,000 for every unit of platelets that you administer. Some people may have hypersensitivity reactions to platelets. So they may form antibodies to the platelets. So these are typed, yeah? So you're gonna make sure that you type platelets, that you're giving the correct type of blood component for the platelets. And platelets don't last a long time. They have to be used within 5 days of the donation. You can keep it at room temperature platelets, depending on the storage and how they collected it, but most platelets can be kept at room temperature. Albumin is a colloid. What's a colloid? A colloid is something that's going to pull fluid into the vascular space, right? So albumin is a colloid. So we're going to give this as a blood expander, right? It's going to pull fluid into the vascular space. So it's a plasma derivative, and what it does is it expands blood volume. It also replaces protein. It's used to treat shock because it pulls fluid into the vascular space. We're going to talk about shock this semester. People that have third spacing, again, because it's going to pull fluid into the vascular space. People that have hypovolemia. People that have low albumin levels, hypoalbuminemia, right? People that have liver failure, for example, often have low albumin levels because liver makes albumin. People that have burns, they are going to be leaking their albumin. And sometimes for surgery, they're going to give them a blood expander. So these albumin comes in different concentrations. It can be anywhere between 5 to 25% solution. So again, it's a blood expander. It's gonna, we all have some albumin in our within our blood vessels, and it's what causes our osmotic pressure, right? Albumin pulls fluid into the vascular space. So colloids, when you give colloids, it's gonna cause an osmotic gradient. It's gonna increase intravascular volume. Another type of blood component is fresh frozen plasma. And they also vary in their volume, right? So usually fresh frozen plasma, a unit has somewhere between 250 milliliters per unit. This fresh frozen plasma is rich in clotting factors. So anybody that has a deficiency in clotting factors will get fresh frozen plasma. A group of people that often have low clotting factors is people, again, with liver failure, because the liver makes our clotting factors. So who would be some people that would receive fresh frozen plasma? It's given for people to treat DIC. You learned about DIC in your PEDS class, and we're going to talk about it again this semester. Disseminated intravascular coagulation, where you're using up all your clotting factors because you're making a whole bunch of little clots. And we'll talk more about that later on in the semester. To reverse the effects of Coumadin, so if somebody has had too much Coumadin, they've overdosed on Coumadin and they're bleeding, to reverse those effects, we might give them the clotting factors. Like I said, the clotting factors are made in the liver, so people with liver failure often have low clotting factors that risk for bleeding, so they might get FFP. And it's also a volume expander. So people in hypovolemic shock, we're going to be talking about hypovolemic shock in a couple of weeks. It's a volume expander, so fresh frozen plasma might be ordered. So it's separated from the whole blood, and then it's frozen. So the liquid portion is separated, the fresh frozen plasma is separated from the cells, and then they freeze it. So that's why it's called fresh frozen plasma. There are no platelets in the fresh frozen plasma. And once it thaws, you have to use it within 2 hours of it thawing. So it's frozen, you have to thaw it before you can use it, but once you thaw it, you must use it within 2 hours. And what's the outcome of giving somebody fresh frozen plasma? It's going to improve their coagulation. It's going to improve their PT and PTT lab values. You can also give them cryoprecipitate. Cryoprecipitate has specific clotting factors. It has clotting factor 8, clotting factor 13. It's got von Willebrand's factor and fibrinogen. So they take out these specific clotting factors from the plasma and they make cryoprecipitate. It's used to treat clients who have these specific clotting factor deficiencies. It may cause ABO incompatibility, so you want to make sure that they're typed and crossed. And it's prepared from fresh frozen plasma. So they extract these clotting factors from the fresh frozen plasma. These can be stored for up to a year, but once you thaw it, they must be used. So cryoprecipitate can be stored frozen for up to a year, but once you thaw it, it needs to be used. Now, some people, well, an autologous blood transfusion is often used in, not often, but sometimes used in surgery and in some emergency settings, where they collect their own blood if they're scheduled for surgery, or in an emergency situation, they can try to salvage the blood in a cell saver if they're losing a lot of blood during surgery. There is risks and benefits to this. There's special equipment that's required in order to do this, but you don't have to type and cross because they're using their own blood. There's minimal risk for an allergic reaction. However, anytime blood goes through a machine, it's at risk for clotting. So this blood is going to have to be heparinized, or it's going to clot when it goes through the machine. If they have a rare blood type, then they can use their own blood because if it's difficult to find that blood type. No risk for developing for contracting a donor's disease such as hepatitis or syphilis or HIV. Even though the risk is low, there is still a risk from getting these diseases when you receive blood from a donor. It's safe, it's well tested. There is going to be some drainage from this autologous blood transfusion, and so you can't use it 24 hours after it's been spinned in that machine. So if it's been there for more than 24 hours, it's going to contain pathogens. So you have to clean it and sterilize it between use. So that's an autologous blood transfusion machine. They also have a cell saver machine that collects blood that's lost during surgery. It cleans it and returns it to the patient's body, all in a continuous loop. So who can make an autologous donation? So if you are going to have a surgery and you know that you're going to need blood, you can donate your own blood. That's called an autologous donation. In most places, you have to be less than 65 years old in order to give your own blood, usually. You can't have any serious medical conditions like serious heart or lung disease to give your own blood. And if you want to give your own blood and you want to plan it for a surgery, you need to donate about 5 weeks before the scheduled surgery. And you have to have a hemoglobin level of at least 11 before each donation. And if you donate your own blood, it can be stored for up to 10 years if they freeze it. And it's usually given within a few weeks, but usually it's given within a few weeks of the donation. So there is a low risk of getting a disease from donated blood. The risk is low, but it does exist. About 1 in every 140,000 units of blood there is contaminated with hepatitis B. About 1 out of every 225,000 units of blood, of donated blood, is contaminated with hepatitis C. About 1 out of every million units of donated blood is contaminated with hepatitis A. About 1 out of every 1.5 million units of donated blood is contaminated with HIV. And about 1 out of every million units of donated blood is contaminated with syphilis. So even though the risk is low, there is a risk for getting a disease from blood donation. Another risk is that it could have been contaminated, right? So now you're going to get the risk for sepsis if you have bacterial contamination in the donated blood. And then the most common type of infusion therapy risk is a blood transfusion donation, a blood transfusion reaction. So about 1 out of every 35,000 units of blood are mismatched, and you have a transfusion reaction. And that is just human error, right? So we're going to talk about ways to avoid that error. If you give somebody incompatible blood, the death rate is about 1 out of every 600,000 people. So now not everybody's going to die if you give them mismatched blood, but you don't want to take that risk, right? So you want to make sure that you're following the policies and procedures of your hospital and that you are giving blood following all the protocols to avoid this transfusion reaction. So you can have different types of reactions. You can have an allergic reaction. You can have an incompatibility reaction. You can have an anaphylactic response to plasma proteins. And we're going to talk about the different types of transfusion reactions and the different signs and symptoms associated with those and the different treatments. Another infusion therapy risk is that you could have fluid overload by giving blood, especially if you're giving whole blood. With packed cells, less risk, but you're going to monitor your patients for signs and symptoms of fluid overload. Our blood is what keeps us warm. Somebody that has lost a lot of blood, they're going to get hypothermic. And now you're going to give them blood that is cooler than what's inside of your body. And so now they're high risk for hypothermia. So if you're going to give massive blood transfusions, you want to make sure that you're using a blood warmer. You want to warm up that person. If they're needing massive amounts of blood, they're already hypothermic. So you want to make sure that you're warming up that blood if you're giving massive blood transfusions. So it has to be placed on a blood warmer. There's a preservative in the blood that contains citrate, and that citrate can cause hypocalcemia. So if you're giving somebody large amounts of blood transfusion, they could develop hypocalcemia because of this preservative. Inside of the red blood cells is potassium, right? That's the main electrolyte within our cells. And so if you lyse those cells, you're going to release potassium into the bloodstream. So people that are getting blood transfusions are at risk for hyperkalemia, especially if you're lysing those cells. And we're going to talk about ways that we can avoid lysing cells. We can cause sepsis if we're giving them contaminated blood, or if we're not using aseptic technique when we're spiking the blood. So remember that when you're giving anybody IV therapy, you want to make sure you're using aseptic technique to prevent bacterial contamination of the blood. And then they'll develop sepsis. And we're going to talk about sepsis this semester in a couple weeks. Okay, so I'm going to take a short break here, and then when I come back, we're going to talk about preparation for blood administration. Okay, let's continue. I'm going to share my screen again, and we're going to finish the blood transfusion lecture. So now we're going to talk about how do you prepare to administer blood. So first thing you want to do is verify the doctor's order. You want to know what blood component is your doctor ordering. Do they want red blood cells, packed cells? Do they want platelets? What do they want? You want to know what the duration of the infusion is. Do they want that packed cells to go in over an hour or 2 hours? What is the duration that they want you to infuse that blood component? If they have multiple components, oftentimes we're going to talk about cardiac surgery this semester. When you're going to cardiac surgery, oftentimes the doctor will order different types of components. They might order platelets, they might order packed cells, they might order fresh frozen plasma. And if they're ordering multiple components, what sequence do they want you to give those components? Do they want you to give the packed cells first and then the platelets? So what sequence do they want them in? Oftentimes they order pre-medications. What pre-medications do you think the doctor might order? Well, sometimes they order Benadryl, sometimes they order Tylenol, sometimes they order Lasix. If it's somebody that is at risk for fluid overload, they might order Lasix in between blood components or before you administer the blood. And do they have any specific modifications that they would like? For example, a leukocyte filter. Do they want you to hang a leukocyte filter with the packed cells? So verify the doctor's orders and make sure that you know the answers to these questions. So whenever anybody is getting a blood transfusion, you need to ask them if they've ever had a blood transfusion before. And if they say yes, ask them if they've ever had a blood transfusion reaction. So you need to ask this anytime that you hang blood. Anytime that somebody's getting a unit of blood, they need a consent. You need to make sure that that consent is signed before you hang the unit of blood. So verify that the consent is signed even before you go pick it up from the blood bank. And then you need to have the following equipment. The patient needs to have a patent IV. You want that cannula to be at least 20 gauge, or you want it to be bigger, because if you have a smaller than a 20 gauge and you give somebody packed cells, it could lyse the cells, and now they're at risk for hyperkalemia. Yes, so you want to make sure that the cannula is at least 20 gauge. 18 gauge is actually preferred for blood, especially if you're going to give more than one unit, but a 20 gauge is okay. You can use a 22, it's okay for plasma, but you should not use a 22 for packed cells. And you want to make sure that that IV is patent. You're going to need normal saline. You always hang blood with normal saline, nothing else. You cannot hang it with D5W, lactated ringers, nothing else. Only normal saline. You need to have a blood administration set that has a filter. And when you do the checkoffs, you will be doing checkoffs on hanging blood. You want to make sure that you'll be able to see the different types of blood transfusion sets with filters. So there's two main types of blood transfusion sets. One has an inline filter, so here's the blood filter. And you also have wide tubing. So the wide tubing, you hang the normal saline on one, one infusion port, and you hang the blood on the other, and then here is the blood filter. So when you spike it, you're going to spike the normal saline first, when you're using wide tubing. You're going to make sure that this is clamped. You're going to spike the normal saline first, unclamp it, unclamp this one, and you're going to make sure that you prime the tubing with the normal saline. So you're going to prime the tubing with the normal saline all the way to the end. Yes? Then once you have primed the tubing, you're going to close this clamp and close this clamp, and then you're going to spike the blood. Or if you had already spiked it, you made sure that this clamp was closed while you were priming the tube with the normal saline. Then you clamp this, and then you're going to unclamp this. So now you're going to prime this tubing up to here, and you want to make sure that that filter is completely covered with blood and normal saline. So you're going to prime the tubing until this filter is completely covered. So you can squeeze this chamber here to get the blood to drip into the chamber. And you want to cover the filter. And then you're going to clamp this, and then you're going to attach it to the patient, right? So you're going to do the sash where you're going to flush the patient's IV with saline. Then you're going to administer the product. You're going to hook this up, and then you're going to open up this clamp. This stays closed. You're going to open up this clamp, and then you're going to regulate it, how fast you want it to go with this clamp. So this is the regulator. Okay, so you're going to regulate it with this clamp. So you want to make sure that when you hang the blood and when you spike the blood and you start to prime it, you want to make sure that this is clamped, or else what's going to happen? The blood is going to go into the normal saline. Now, this is what a blood warmer looks like. When would you use a blood warmer? When you're giving large amounts of blood. When you're giving massive amounts of blood, you want to make sure that you put it on a blood warmer. Why? Because blood is what keeps us warm. So if Patient has lost a large amounts of blood. They're already hypothermic, so you want to make sure that you warm that blood up. A pump. Not every pump can be used for blood. Some pumps will lyse the cells. So you want to make sure that if you're using a pump, that that pump is made for red blood cells. Most often, for adults, we do not put blood on a pump. If it is put on a pump, it has to be a specialized pump that you want to make sure that it's compatible with blood. Pediatric patients, they oftentimes will put a blood pump on pediatric patients. For adults, it's usually by gravity. This pressure tube, this pressure bag. Some hospitals require you to have a doctor's order for a pressure bag. When would you use a pressure bag? If it's going too slow, you want to increase the rate of infusion. So what's the first thing you do if you want to increase the rate of infusion? Well, you put it up higher, right? So you keep increasing the height and increasing the height of the blood. Well, you got it all the way up to the ceiling and it's still too slow. Then you might put on a pressure. You might put the blood in a pressure bag to increase the rate. Some hospitals require a doctor's order for a pressure bag. So know when to use a blood warmer, know when to use a pressure bag, and know the limitations of a pump. So how are you going to prepare the patient? You're going to assess their concerns, explain to them they're about to get blood. They've signed their consent form. You've asked them whether or not they've ever had a blood transfusion reaction before. If they say yes, you're going to ask them if they've ever had a blood transfusion reaction. You're going to explain the procedure. You're going to say, I'm about to hang blood. And you're going to explain to them what to report. If they have anything funny feeling, let me know. You're going to stay with them for the first 15 minutes at least. You're going to check vital signs before you hang the blood. And then every 5 minutes, those first 15 minutes, you're going to stay with the patient. You're going to explain all that to the patient. You're going to tell them what signs and symptoms to report. We're going to go over the signs and symptoms of a transfusion reaction. But basically, I tell them, if you feel anything funny, let me know. But you can go through the list of signs and symptoms. You want to maintain their comfort as they're getting their transfusion. Like I said, you want to get baseline vital signs. Before you hang the blood, you want to know what their vital signs are. You want to listen to their lungs before you hang the blood. Why? Well, you want to hear if they have any crackles or any signs and symptoms of fluid overload before you even hang the blood, right? So you're going to check that. Check the skin condition. Why? Because one of the signs and symptoms of a transfusion reaction is to get a rash, right? So you want to make sure they don't have any rashes before you even hang the blood. Assess the patient for pain, especially back pain, before you hang the blood, because back pain could be a sign and symptom of a transfusion reaction. If they already had back pain before they even started the blood, well, you might not attribute it to the transfusion. You're going to assess pertinent lab results. Well, what are the pertinent lab results? It depends on which blood component you're hanging, right? So if you're hanging packed cells, you're going to check the H&H. If you're hanging platelets, you're going to check the platelets. If you're giving cryoprecipitate or fresh frozen plasma, you're going to check the coag studies, yes? So depending on what blood component you're giving, you're going to check the pertinent labs. Pre-medicate them as ordered. The doctor order Benadryl, Lasix, Tylenol. Those are the most common pre-medications. And then you're going to get the blood from the blood bank. Once you get the blood from the blood bank, you need to start it within 30 minutes of getting the blood. So if something happens and you cannot hang the blood within 30 minutes of when you got it, what are you going to do? Are you going to put it in the refrigerator on your unit? No. You're going to send it back to the blood bank. But you need to use it within 30 minutes from the time you get it from the blood bank. When you go to the blood bank, you're going to sign for the blood. Remember, you only can get 1 unit of blood and only 1 unit of blood for only 1 patient. So you're going to do a complete identification check with another licensed nurse or the physician. So it's going to be with another RN, or you're going to do it with a doctor. So you're going to make sure that you check the patient's name and ID, an ID number. You're going to check the doctor's order. You want to check the blood bank ID number and the unit number. You want to make sure that they have the right ABO group and type. And you're going to check the blood for appearance, for color. You want to see if there's any clots or gas bubbles. If you see any of those things, you're going to send it back. And you're going to look for the expiration date. So on this blood bank, it tells you, on this blood bag, it tells you where to find the different things on the label. So you're going to look at the label with another nurse, and you're going to check that with the tag that's going to be, there's a tag that's going to be hanging off of the blood. You're going to check with the tag and the bag and the patient's ID band. So then you're going to prime the administration set and filter with normal saline. Remember, it can only be primed with normal saline. No other fluid can be used, only normal saline. You're going to invert the bag gently several times to suspend the components. You want to make sure that this blood filter, once you prime it, is covered with blood. So when you get checked off, your clinical instructors are going to ask you to demonstrate how to use a Y set and an inline filter. So they're probably not going to have each of you spike bags and do the whole thing, but you need to be able to talk them through it, right? So you you spike the normal saline first, you open up the clamps, and like I said earlier. So you're going to spike the bag, prime the tubing, stop the normal saline. Then you start the blood component. You want the blood component to be about 2 milliliters per minute for the first 15 minutes. You're going to assess and record their baseline vital signs before you hang the blood, and then you're going to check the vital signs every 5 minutes for the first 15 minutes. You stay with the patient those first 15 minutes. Why? Because that's when most transfusion reactions occur. They're going to occur within the first 15 minutes of you hanging the blood, usually within the first 5. But you're going to stay with the patient for the first 15 minutes. You're going to check vital signs every 5 minutes for the first 15 minutes. You're going to look for signs and symptoms of a transfusion reaction. So you're going to tell the patient before you hang the blood that if they have any of these signs and symptoms, to let you know right away, right? If they get short of breath, if they're itching, if they have a rash, if there's any pain at the IV site, if they complain of chest pain or lumbar pain or flank pain or nausea or vomiting, right? So you're going to assess for that. So these are the signs and symptoms of a transfusion reaction. You're going to need to be able to verbalize these signs and symptoms when you get checked off. So if there's no sign and symptom of a transfusion reaction the first 15 minutes, then you can increase it to the ordered rate, right? So you were hanging it at how many cc's, how many milliliters per minute the first 15 minutes? 2 milliliters per minute, right? That's the maximum amount the first 15 minutes. After 15 minutes, if their vital signs are fine, you can increase it to whatever the ordered rate is. You're going to then monitor your client every 15 minutes during your transfusion or per your agency protocol. So the KCC hospital is every 5 minutes the first 15 minutes, and then every 15 minutes the first hour, and then the second hour is every 30 minutes after that. So that's the KCC hospital, but you're going to follow the policy and procedure of whatever hospital you are for their protocol for how often you check the vital signs. You're going to assess them every time you get the vital signs for any signs and symptoms of a transfusion reaction, and every time you get the vital signs, you assess the IV site. You're going to look for other complications besides those of a transfusion reaction. You're going to look for signs and symptoms of circulatory overload, right? You're going to listen to their lungs and see if they have any signs and symptoms of fluid overload. You know the signs and symptoms of potassium toxicity. That should be a review for you. So look it up. What are the signs and symptoms of transfusion of potassium toxicity? Often it's going to be EKG changes. Hypothermia, right? When you're giving them blood, they're at risk for hypothermia. They're at risk for hypocalcemia. Why? Because of the preservative, right? The citrate preservative. Know the signs and symptoms of hypocalcemia. That is review for you, so review that. And then they could go into septic shock if they have a contaminated blood. So you're going to complete the transfusion within the ordered time. Usually it's going to be about 2 hours. Usually they want you to hang the blood, but the maximum amount of time that you can hang blood is 4 hours. You cannot hang blood for any longer than 4 hours. Now there might be a little old lady that is at risk for fluid overload, and the doctor might think that a unit of blood over 4 hours might be too much for that person. The doctor could order to split the unit. That is done in the blood bank. So if the doctor thinks that the patient can't handle the unit of blood because it will cause fluid overload, the doctor can split the unit. It's split in the blood bank where you're going to get half a unit. You're going to hang it, or you can hang that half a unit over 4 hours and then get the other half and hang that one over 4 hours to decrease the risk of fluid overload. So that's what split the unit means. Once you have completed the transfusion reaction, the line needs to be flushed with normal saline. You're going to document the time the transfusion was completed, the amount of blood that was infused, the patient's vital signs, assessment, and whether or not they had a transfusion reaction. So all those things are going to be documented. You're going to discard the blood bank and the tubing in a biohazard waste bag according to your agency's policy. If your patient has a blood transfusion reaction, you're going to stop the blood component. You're going to remove the blood and tubing and start normal saline with new tubing. You're not going to use the tubing that already has the blood in it to give them normal saline, right? Because that's going to, you want to stop the blood and you don't want to give them any more of that blood. You're going to call the doctor. The first thing you do is stop the blood, yes? Stop the blood, remove the tubing, start normal saline, then you call the doctor. You notify the blood bank, let them know your patient's having a blood transfusion reaction. You're going to assess their vital signs. You're going to assess and document their signs and symptoms. And then you're going to follow whatever orders that your doctor gave you based on the type of transfusion reaction. You're going to get blood samples and urine samples. You're going to save the blood component. You're going to save the tubing. You're going to save the filter. You're not going to throw those away. You're going to complete a transfusion reaction report. Each agency has one. You're going to follow your hospital's policy for completing that report. Here's an example of the University of California, Davis Medical Center, of their blood administration record. And so here they have the date, what type of blood did you give, what was the unit number, what was the blood type, what time did you start the transfusion, what time did you end it, were there any pre-medications ordered, yes or no, what was the pre-transfusion, what was the baseline vital signs. Here it looks like they get vital signs every 15 minutes instead of every 5 minutes. So again, you're going to follow your agency's policy. So you're going to write down the vital signs. And then what were the vital signs at the end of the transfusion? Did you use a blood warmer? Yes or no? Did the patient have any signs and symptoms of a transfusion reaction? Yes or no? Here are the signs of an acute reaction. Here are the signs of a delayed reaction. If they have a transfusion reaction, here is the workup that they do in that particular hospital. So you're going to have a form that's like this, and you're going to make sure that you fill out that blood administration form. Now there's 4 main types of transfusion reactions. There's an acute hemolytic reaction, a delayed hemolytic reaction, a non-hemolytic febrile reaction, and an allergic reaction. Each one of those types has different signs and symptoms, and you treat each one of those reaction types differently. The most life-threatening reaction is going to be a hemolytic reaction, and that's due to ABO incompatibility. The red blood cells are being destroyed because you gave the patient the wrong blood type. The most common type of transfusion reaction is going to be a febrile reaction, and that's because the patient was sensitive to the donor's white blood cells, platelets, or plasma protein. So febrile reactions, if they've ever had one, the doctor's going to order a leukocyte filter. They could have an allergic reaction to the donor's plasma proteins. These allergic reactions can be mild or it could be an anaphylactic reaction. So you're going to find out if your patient has ever had a transfusion reaction before you hang the blood. And then if they've had, let's say they've had a febrile reaction in the past, the doctor might order Tylenol, might order Benadryl, and might order a leukocyte filter. So here's the different types of reactions. I want you to learn these on your own and be prepared to discuss when you check off. Yes? So today, I'm going to, on Friday, I'm going to break you up into groups and I'm going to let you guys check each other off in Zoom. And then when you come to the lab, you're going to be checking off in person. And one of the checkoffs is going to be able to verbalize what are the different types of reactions, what are the causes, and what's the nursing care. I'm not going to read this to you, but be familiar with this table. Okay. So there's going to be more that we're going to learn on Friday, but I want you to at least know what's on this PowerPoint when we meet on Friday, and come prepared with any questions that you have, anything that you didn't understand. Okay, thank you. See you on Friday.